Good. And then we can do the 4 finger prick samples.
The world. It can be a scary place. But if you're going to make people better and cure illness, you got to hit the road. The adventure of research doesn't happen in a vacuum. It happens everywhere, and it happens all the time. People are on the move constantly, so things that make us sick are on the move right along with them. Diseases that haven't even been seen in the States for generations are popping up more and more. Things like dengue fever.
Dengue fever comes from mosquitoes, and it can kill you. It may not seem like a big deal to you, but here in Guangzhou, China, this is the tropics. Dengue fever is a big deal. In fact, about 2/5 of the world's population is at risk of getting this deadly disease, and it's starting to show up in the United States. There's no cure, there's no treatment, but a new idea that may sound pretty simple may be the best way to get rid of this disease. The idea is to get rid of the mosquitoes. Zhang Ji is here from MSU. He's partnered up with Sun Yat-sen University, trying to find a way to stop this deadly disease.
Dengue is the most important disease in the south part of China. There's no vaccine and no drug available. And the technology we develop, we hope to use in for future for the disease control of this country or even worldwide.
Instead of working on a cure or a treatment for dengue fever, Xi is developing a way to remove the virus from these bloodsuckers in the first place. So, if there's no virus in the mosquitoes, they can't infect people. To pull this off, Xi needs a lot of help from the government here. Director Ming Wang of the Guangzhou Center for Disease Control knows that containing the dengue outbreaks is crucial, especially in rural areas.
This village have the dengue outbreak in the past. The CDC come to here and collect the mosquito larvae and also those eggs. So we target to get 70% of the local community support. Then we think we can do the work in this field side.
With all the lives on the line, all around the world, his work is sure to create the much-needed buzz to get a lot of people behind it. Mosquitoes are behind some of the worst things you can get. Malaria kills millions every year, and it's especially hard on kids. It was mostly wiped out in the U.S. decades ago. Used to be, even East Lansing was a bad area for malaria. That's all changed because of insecticides and other stuff, and the deadly disease has vanished from our American radar. But in Africa and a lot of other tropical hotspots, fighting malaria is a daily battle.
When I touch you, does it feel normal?
Terry Taylor with Michigan State University spends half the year, the rainy season, here in Blantyre, Malawi.
Why is the work that you're doing here so important right off the bat?
Well, malaria is a major cause of both morbidity, sickness, and mortality, death in Malawi. A third of hospital admissions are related to malaria, and about a third of the deaths. So it's an extremely common cause of both illness and death.
And malaria, like dengue, is making a bit of a comeback in the United States. Researchers say that as the climate changes, these diseases are showing up in places they haven't been seen for decades or have never even been seen at all. Ground zero for tackling these mosquito-borne illnesses is Africa.
This is Chickenkata, Zambia, and this is malaria country, and I don't want to get malaria. So I'm taking one of these little pills every day. Malaria can make you sick, it can kill you, and it's particularly dangerous if you get it when you're a kid. It can also bring complications and lead to things like epilepsy. Most of the millions of people who are at risk for getting malaria every year can't afford these little pills, and that's a big problem.
So my PhD work is looking at the intersection between HIV and epilepsy.
MSU's Melissa Elefross is working on the connection between epilepsy caused by malaria and HIV and the stigmas that go along with both diseases.
Oftentimes people with HIV have other medical conditions, and in developing countries, oftentimes it's epilepsy.
This trio of diseases is responsible for millions of deaths in Africa and around the world every year.
So I'm looking at two different things related to HIV and epilepsy. One is drug interactions between the medicines you take for both conditions, and the other is stigma. Because in settings like Zambia, both HIV and epilepsy are highly stigmatized.
Benjamin lives in the tiny village of Chikankata in Zambia. He's got epilepsy. It carries a stigma that goes way beyond the illness. Thanks to new treatments, his symptoms have vanished. Now he spreads the word to others so they can find help.
Benjamin says it's one of his tasks he does every day, and he always thinks about it. He usually meets a lot of people. He can even go in the communities wherever he hears there's a problem of such, and then talks to them and encourages them never to go for African herbs, but to come to this epilepsy treatment, because he has seen great things changing in him from his experience and what has happened to him.
Taking away the awful stigma of having epilepsy here is rough. Getting at the problem of making these people fit in is tricky.
We are looking for people that have fits, because we're trying to better understand what life is like. Because I know it can be hard, yeah?
Yeah, sure.
So,
Do people ever say that you've been bewitched or something like this?
I don't listen.
Don't listen to us.
no. Good for you. Good for you.
More than 50 million people live with epilepsy, and almost all of them, about 80%, live in developing countries like this. It's not about taking little pills, it's about pushing hard to make a huge cultural change happen. These new drugs and new treatments are ending the symptoms that scare people. And, thanks to MSU and people like Melissa Elefross, word is starting to spread that things like epilepsy aren't witchcraft. That it's just an illness and that it can be treated. Stop the seizures, stop the stigma. It means living a better life for lots and lots of people, people like Benjamin, right here in Chikankata, and all over the world. Hands-on care is something people all over the world are looking for, but qualified doctors can be really hard to find in developing countries and in the hard-scrabble, poverty-stricken points on the globe. Medical missions take young doctors and medical students from places like Michigan State to places like the Andes Mountains of Peru.
We are in Huamachuco, Peru, and we are going to perform a test called the PACER test, and it's pretty much used to determine cardiovascular health in adolescents, pre-adolescents, and children. This is an elementary school, I believe, at the moment, but there's other ages that we're going to be working with.
Okay. So you write the second lap here, you write the first lap just...
We're up 10,000 feet. Obviously, there's less oxygen up here. We want to see if that has an effect on the cardiovascular health of these children. It didn't translate too well, so we ran an example for Group B.
Okay, are we going to run the example, or
yes.
we're going to have the children run it?
No, we're going to run it.
Okay.
They're just going to watch us.
Okay.
It's run a lot in United States in gyms, and it's to get a good indication of where the children are in regards to their cardiovascular development. You know, they've been here for generations, but it hasn't been yet studied to see if it's comparable to, you know, let's say someone at sea level doing the same test, growing up in the same environment. In regards to nutrition, their diet is mostly starches and a lot of potatoes, a lot of rice, not much protein either. We found that like a lot of times they're protein deprived, and we want to see if, you know, that plays any role in their cardiovascular health as well. This is through MSU COM. It's not my own particular research. The trip that we go to Peru happens every year, and it's kind of become this longitudinal type study where we come every year to collect data. We're pretty much following these children to see their development and to see what factors are involved in this development. Like I said before, it really hasn't been studied, like this particular type of population and this elevation in South America. So we're hoping we can find something useful and maybe help them if their cardiovascular development is subpar.
Gracias.
And docs are dispatched to a lot of the neediest places, not only to give one-on-one care, but also to set up new clinics and create innovative ways to treat those who need it most right in their hometowns.
All these people around me are waiting to get into the emergency room at Mérida, Mexico. Once they get in, it could be a couple of days until they actually get seen by any doctors. They're used to this. The College of Osteopathic Medicine and Michigan State University are trying to make a difference here in both the level of care and the access of care, and they're trying to bring a very valuable teaching and learning experience here to Mexico. Dr. Jake Rowan is the man leading the effort on the ground.
This is the reception for the outpatient, the waiting room.
All good ideas start with a solid foundation. Well, here's the foundation. Dr. Jake Rowan is working on the idea.
How many other osteopathic clinics are there in Mexico?
None. This
None.
is the first one.
So this will be the first osteopathic clinic in Mexico.
In Mexico, and it will be the first teaching osteopathic clinic.
Perfect.
So he and the College of Osteopathic Medicine are putting a lot of hard work into turning this foundation of a place into the foundation of a healthy city.
My goal here is to create a platform on which we can continue to work so that our students can get educated. And in the process of our students being educated, we're helping the patients.
Dean William Strample saw the need here, put the wheels into motion.
When I was down there the first time, I toured the hospital. And I'm a pulmonary disease critical care specialist, and they had a 14-year-old boy in the ICU dying of tetanus. And I haven't seen tetanus in the United States in about 40 years. So I thought, this is exactly what I want some of the medical students in our school here at Michigan State to really get exposure to while they're in school, so that they see there's a different level of medicine besides what we're used to in the United States.
From his office on campus, he's connected to Mérida. He and the college wanted to work with the Yucatan Health Department and make this place better. A lot of the people here have diabetes and related kidney problems. That meant a need for dialysis machines. MSU worked it out, so they got 16 of them.
The hospital just hired a second nephrologist who will do both internal medicine and nephrology to help transition some of the patients off of peritoneal dialysis onto hemodialysis. The equipment alone won't do it, the people alone won't do it. You have to have a combination of the people and the equipment.
Part of the construction is our clinic, MSU Comp Clinic, which we're going to go inside now. I'm going to show you how the clinic is under construction. It's very close actually to be finished.
At the beginning, I made it very clear on behalf of Michigan State University that this is an equal collaborative relationship.
And it's going to be an osteopathic clinic and a hospital for the people of the Yucatan community. And I believe that research helps develop better ways to treat patients, and not only in osteopathic medicine, but in all of medicine.
The research component to this place would be looking into translational research, especially in diseases that are very common in the Yucatan. Now we're going to take it to a higher level, and that is how we can incorporate, and hopefully after this facility is ready, a clinical translational research between the faculty of Michigan State University and the doctors here, to the point, that we will make a great impact together.
Research is definitely can be hands-on, and I think we're going to show it here.
Jake Rowan is here to bring this idea to life. He and his family moved here, and he didn't even speak Spanish.
I took like a beginner's class, the first week I was here, which helped a lot, but I'm still not a good Spanish speaker. I can get by.
He's actually improving a lot in a short time.
That my colleagues tease me about it, and my wife teases me about it more than anybody else.
It's amazing what people have the will to do if they really want to. And lives will be saved, and lives will be able to be lived better because of the work being done right here and the connection to Michigan State.
A lot of the diseases around the world aren't transmitted person to person, but the need for treatments and cures surrounds us. No matter if you're in China or India or Michigan, people around you are suffering from things like cancer and heart disease and Parkinson's, and they need help.
Every year, about 60,000 people find out they have Parkinson's disease here in the United States. Worldwide, it's estimated that between 7 and 10 million people are living with it. The earlier it's diagnosed, the easier it is to treat. That's where MSU's Raul Shrivastava comes in.
Out of his finger formed a scab.
We try and design ways to capture very, very small changes in speech.
The boat sailed along the coast.
And we try and study what part of the speech production system changes with a disease, how we capture or interpret those changes from a speech signal, and then try and track those changes over time to see when a person may be showing some very, very early symptoms of the disease or how the disease may be changing over a period of time. We are wondering if, for example, if we ask you to say papa, papa, papa really quickly, how long can you keep it up and how accurately can you keep it up?
Peter Hasbrook has Parkinson's. This revolutionary way to find out if someone has it gets it right about 90% of the time.
One, it's completely non-invasive. Two, it's very quick. It's capturing what you do on a daily basis anyway. Third, it's portable. It can go with you. You can record it, send it back to us, and we do the analysis on the back end here. So that allows you to really study the disease much more frequently in a patient's natural environment at very, very low cost.
The stuff this software picks up is too small for people to notice. Raul says everyone with Parkinson's has some type of speech issue and that those show up sooner than problems with muscles and movement.
A lot of times the patients go several years with the disease before a formal diagnosis is made. With this, we can help move that diagnosis line a little bit sooner. It can help track changes over time, so you could use that to see whether the drugs you're taking are working or not, or the exercise you're doing are working or not. It can help you see how a person responds to just environmental influences, and then you could do it repeatedly instead of having to go see a doctor every 6 months or once every year. You could do this much more frequently.
At first, his work was funded by the Veterans Affairs Department, but that ran out. His group has patented the software, and now he's out trying to secure more funding to keep this important research running, so help can come to those who need it so badly. Heart problems kill a lot of people everywhere, every year. It beats and it keeps us alive. It's our engine. But all engines break down sometimes, and that's not so bad when it's just an engine. But when that engine is your heart, big problem. A new heart monitor is coming to life here at MSU, and Ramakrishna Mukamala is behind it. Describing how it works is a little complicated, and it's still a secret since it's awaiting clearance from the FDA before coming to market, so I can't say too much about it. But basically, his system means blood flow can be monitored without the catheter that's often inserted into the body and used to monitor blood flow. If a catheter is in place, this thing will take that information along with the data from monitors that just go on the outside of the body and give doctors a clearer, more accurate idea of what the heart is doing. It will also work with monitors that just go on the skin. It will be for anyone who has to be constantly watched for any changes in the beating of their heart. It'll come to life to extend life.
Raytia's monitor will ultimately measure minimally invasive and non-invasive physiologic signals, analyze the signals to compute cardiac output based on patented algorithms, and then display the cardiac output and other information to guide the physician in managing their patients.
And as this idea comes to life here, it could just keep your heart going and help keep you alive out there, wherever you are. The idea is to save lives, keep hearts beating, and it's all happening because MSU's Ramakrishna Mukamala had an idea and the will to bring it to life. The adventure of research is an expedition without end. These explorers of today might use an occasional compass, but the biggest discoveries come at the end of a microscope, not a spyglass. And while they're not discovering any so-called new worlds, they are identifying and exploring new worlds of knowledge and science And every day they are making discoveries that can lead to new cures, new treatments, and longer, better lives in these old worlds we call home.